Good afternoon, and welcome to the CIO's Role in Battling the Opioid Epidemic, a webinar tweet chat combo from healthsystemcio.com, produced in partnership with Chime and sponsored by ClearData. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate on your phone or in a separate browser by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. We're encouraging you to send in your questions. Leave the default set to all panelists. You can send them in as they occur to you, and we'll take them later in the program. And you can download the deck by using the URL on your screen. It's at the bottom of our slides, and it's also been sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to go about 35 minutes with our main panel discussion featuring Ed Kopetsky, CIO, Stanford Children's Health and Lucile Packard Children's Hospital, Stanford, Jim Turnbull, CIO at University of Utah Hospitals and Clinics, and John Cruz, CEO of ProveIt. So without further delay, we are going to jump right into our conversation. Let's start off with you, Ed. Can you give us an overview of the organization where you work and your role there?
Sure. I've been here almost 10 years. I'm the CIO of Stanford Children's, and really in the last 5 years, we've gone from a very high-end tertiary quaternary hospital to a major children's health system in Northern California. And as I mentioned, we're tertiary quaternary, so we have kind of the highest acuity of patients in children's healthcare in the country. And we're clearly here to improve medicine and curing children's diseases. It's a combination play with Stanford Medicine and the School of Medicine, and you know, we're very fortunate to have the backing we do and the kind of things and advances we're doing.
Excellent. Thank you, Ed. Jim?
Jim Turnbull. I'm the CIO of the University of Utah Health in Salt Lake City. I've also, like Ed, I've been here for approximately 10 years. The university serves about 10% of the geographic U.S., and we cover about 7 states. One of our sort of unique aspects here is that we have a very busy burn unit, and probably one of the top burn units in the U.S. It's in our area. One of the issues that we've had to deal with for many years is the abuse of both, marijuana, opioids, the whole thing, and we have a task force that I'll talk about later on addressing that issue.
Very good. Thank you, Jim. John?
Good morning. I'm the CEO of ProveIt, which is a technology and clinical platform aimed at prevention within the opioid crisis, merging systems architecture and big data and clinical aspects such as education and preventive behavioral counseling. It's a new tech startup, been in business about 2 years.
Very good. Thank you, John. Thanks for joining us today. All right, let's get into it. Jim, you want to start us off here. Tell us how you came to this issue and why you've decided to dedicate so much time to it.
Well, it's certainly an issue I've been familiar with for the past 10 or 15 years. And as some of you may know, Salt Lake City is an area where a lot of the black tar heroin issue really exploded out of. A group came in here from California, and it's been a really bad situation in this city. And it might surprise people knowing the predominant religious faith in our state. Some of the cities that have really been hit hard include Provo, Utah, which is the home of the Brigham Young University. It's really been a significant problem for our state, certainly like many others, but as people have been addicted to opioids and can't afford the prescription stuff anymore, black tar is the alternative. We have a very serious suicide problem in Utah. Much of it is caused by the opioid problem itself, and we were the 5th highest rate of suicide of any state in the U.S. So all of this stuff kind of ties together. More personally, and Ed's going to talk about this in a moment, but Ed's been a dear friend of mine for over 15 years. I've known all members of his family for that time. His daughter used to babysit my kids. And Tim, who Ed will talk about in a moment, passed away last October 3rd. And he used to be one of my golf buddies. And so the relationship's been very close. And when we decided to pay attention to this issue, I was willing to jump in immediately. And the nature of the issue is very personal for me, but it's also professional given the magnitude of the issue in our state.
Thank you, Jim. Ed?
Well, I think Jim hit on it. Our family experienced opiate addiction. My son got addicted in college, like many do, and came for help. And after 6 years of trying to stay and recover and failing, we intervened and moved our son to Dallas into some of the best care in the country. And unfortunately, he was 4.5 years sober and 2 months from finishing his degree, and one of his friends relapsed and overdosed but survived, and his friend's wife called Tim to help by cleaning out their apartment, and for the first time in 5 years he came into contact with heroin and succumbed within a couple hours. And his friend also, who overdosed and survived, came back home and must have had some left, and he also died. It is a tragedy, incomprehensible, but happening, 120 times a day now. And it speaks to the power of these drugs that even after you've been through, all the best care in the world, addiction it's not well understood. And here was a person at his highest points in the best of care and moving on, and all it took was, availability for an hour, and he just lost control. He had, so it comes out that, Jim was at our service for Tim, and I was exacerbated and said, God, I hope something good can come from this. And so Jim and Russ and others thought about this task force for Chime and asked me to help on it, and of course I agreed. But I must say it's the most striking thing for me was our first meeting, and we had over 30 people there from multiple CIOs, organizations, and all the vendors, and everyone had a story. And it speaks kind of similar 20, 30 years ago, like AIDS. AIDS was this weird thing, and it was isolated to weirdos and all these labels. Well, all of a sudden there was Magic Johnson and others, and it became normal. And that's the only way we're going to address this. I hope by our task force and our other things that we can both kind of give advice to healthcare organizations on how to help, but more importantly, change the stigma of addiction. It clearly is a disease, and we're finally getting around to insurance companies helping, but we're way off yet from where it needs to be. And I'll leave it there. There's more comments coming, but I want to just say, as a parent and a healthcare leader, that's why I'm doing this.
Thank you. Thank you so much for that, Ed. John?
Thank you, and it's a sobering reality with the crisis that we're facing. much the same reasons that my two counterparts have faced is why I'm here. I was in a large publicly traded company and got tired of the political game and the nonsense that goes on trying to climb the ladder, stepped away, approached my physician partner and said, I've got an idea that I want to go and become an entrepreneur and tackle. And the idea wasn't aligned to the opioid crisis. It wasn't on my radar just yet. I've heard of it, seen it in the news, but wasn't where my skill set was at, but it was where his is. And we had a hypothesis that if we create the right systems infrastructure to make the right customer experience, could we get to the true definition of prevention within the opioid crisis? And if not, once apparent behavior addiction sets in, what are the tools needed that we can do to create a differentiating experience to save these lives? And it hits pretty close to home to me because I'm a chronic pain patient. I was in the military, served for several years, a couple years in Iraq, got hit by a bomb, and have been through countless procedures and obviously on medicated therapy right now. And I asked myself one day, I said, I know just enough what's on this bottle of pills. Do I know everything I need to know to be a safe patient, to know when tolerance is kicking in, to know when dependence is kicking in, to know what I need to do to be safe? And so I looked up some data and found that there is a subset of the population that passes away every single day by following the label on the prescription, and that was the bell that rang in the alarm and why ProveIt was born, to see if we can use some of these advanced technology tools that we're familiar with as CIOs within our organization to create a differentiated experience to save our partners and our American lives.
Very good. Well, what a panel, and we're looking forward to this discussion today. I want to thank everyone for being here. Ed, let's go with you first on this. Talk about Chime's Opioid Task Force, its makeup, goals, and progress so far.
Yeah, and Jim, please chime in here. You know, we came together in January, and so it's only been 6 months. Chime, if you're not aware, is an organization for CIOs in healthcare. It also has a foundation of 120-some or 130-some foundation firms, including all the major vendors in healthcare like Epic and Cerner and Allscripts and name it. So we put this together, and I think the board voted to seed some money, and let's get people together in a room and talk about it. And as I said, we were very amazed at our first meeting. Everyone had a story to tell, and here they were as volunteers traveling to Washington for this meeting. And I just want to say it was just very touching that everyone got into it quick, and they kind of dropped their personal interests and started learning about the issue. We had some keynote speakers from SAMHSA and congressional staffers and stuff like that, and we really started to learn more about the disease first. And I think that was so important because we tend to, you know, jump on projects, but not understanding the disease, it would have been really ill-informed. And so we spent some time doing that. And then as we were talking, we said, where can we make improvement? And we're not going to boil the ocean, and we're not going to solve addiction, but what can we do in the short term to help in this crisis? And we broke into eventually 3 main work groups led by 1 or 2 of the task force members. And the work groups, the 3 of them are around public policy regulation and partnerships. We know Chime can't solve this on our own. The second one was evolving a repository of leading practices. What we came to realize really quick is that hospitals are only a component. They are a contributor, but they are not a complete full service for the problem. And so we had to figure out, again, how to network more with community health services and others that are really in the addiction treatment business. We also had to realize the role of hospitals in what is their role in this crisis. And it turned out that because of changing pain management theory in the 90s, it led to the massive use of the morphine molecule in unprecedented doses and prescription levels, almost unbelievable. And so we had to look in the mirror and say, my God, we helped contribute to this issue. And what are we going to do about it? So one of the task forces, and its leading practices, we also have developed a knowledge hub at Chime where we are storing these leading practices that we're discovering through surveys of our membership and networking. And then the third one is just about communication. How do we communicate our findings and our progress, our leading practices, and et cetera, not only to our membership but nationally, and hence that's kind of why we're on this webinar. But that's basically, it's by volunteer members from both the vendor community and the CIO community, and also the Chime staff. And we've literally had 3 meetings already and are making progress on every aspect, both learning and also sharing. And I think that's how we can help.
Jim, anything you want to add to that?
Yeah.
Yeah, I would just comment, one of the things that is underway is the development of a playbook, and what we're envisioning, I believe it's about 8 chapters, and that playbook is targeted for release later this fall. And I think as I wrestle with what's going on here in Salt Lake, the playbook component is something that's evolving. But what I found here locally, there's so many good things going on to address the issue, but a lot of the work is very independent. And as we've reached out, and one of our themes around the task force is to really strongly collaborate with others. And as I look at our friends downtown at Intermountain Healthcare, they're doing some great work. The Department of Public Health is doing great work. Our local CHI is doing great work as well, but we're not tightly coordinated. And I think that's one of the things we need to do within each of the areas we serve across the country. How do we coordinate so that we provide the best care for the patients that are in trouble and get them the services they need? So the playbook will focus on what are the components and how do you try and pull it all together. The information I believe that we have is absolutely key to solving the problem.
Very good. John, I want to give you an opportunity to talk. Ed had mentioned it's helpful to understand the disease from a clinical point of view, you know, even when you're approaching it from the IT side. So you want to do what you can from the IT side to deal with the crisis, but a basic understanding of the clinical side of it helps. So do you want to help provide us with some of that briefly?
Sure, appreciate the question. I think the two live in the same space. If we're going to take a project on in our regular roles or change management issues or even something strategic, one of the very first steps, depending on the methodology that you believe in, is you got to define the problem. You got to understand the problem and understand what the end state is. So as CIOs, as CEOs, as leaders in IT, it's incumbent in us to understand how the technology platforms and our vendor relationships play into that paradigm. So from a clinical side, there's a plethora of statistics we can go through to talk about how this works. Ed talked about a couple of them. You know, one of the earliest ones that we can go to talk about magnitude is about 1,000 people a day are hospitalized across the country from an overdose and live and survive or are brought back. Depending on your data source, somewhere between 120 and 134 overdose and die. And that number has grown about 38% from last year and 28%, 28% from last year and 34% the year before. So it's steeply rising. For us data geeks like myself, it is going into an exponential curve. So it's increasing. And there's a lot of factors that parlay into this. So addiction is certainly one of the ones that we talk about in the clinical setting, but there are others. Polypharmacy is one, and you can, like I alluded to earlier, you can take your medicine purely as prescribed without aberrant behavior and still suffer an overdose from being what's called over-sedated. So let me give an example to talk to that. Let's say you're an athlete, you're a young guy, young gal, and you hurt your shoulder. You go to your ortho, and they give you a muscle relaxer and a opioid painkiller. But you're having a hard time sleeping a few days later, so you go to your general practitioner and he prescribes you a sleeping medicine. And because of the change in physical activity, a week or two later you're in physical rehab, you're going through the process, you see either your general prac or your mental health professional, and they give you an antidepressant. All of these medications, plus 4 others, are what we call the sedative 7 at ProveIt, and they all stack on top of each other. And they lead to a really fascinating quote, fascinating in a terribly depressing way, that I heard from the U.S. Surgeon General in an offsite at Atlanta, which is 51%, his data, the Surgeon General's data, 51% of the people that die from the opioid crisis die alone, at home, at night, in their sleep. See, the general consensus most of America has around the opioid crisis and who the target demographic is it's someone who, the overwhelming majority, the Pareto, 80% or greater, if we listen to just media outlets or even some legitimate data sources, it's a person addicted more than likely to either pills or heroin with a needle coming out of their arm under a bridge. And that's not representative of the full solution. So as IT professionals and as guys and gals who are very methodological and logical, we got to understand the problem and how it interplays. And there's some other complicating issues that come onto it as well. For instance, NANS, neonatal abstinence syndrome. The CDC hasn't updated their graphics on it if you go to Google Images, but if you pull down their latest report, it just changed about 4 weeks ago. It used to be about every 25 minutes in America, a baby was born to neonatal abstinence syndrome. Or in other words, a baby was born to withdrawal. Now it's every 15 minutes. So in every mark, the way that it interplays with our brain, the probability of addiction, the probability of death, the volume of death, the audiences that are impacted from newborn to elderly, socioeconomic classes, it's all unfortunately going in the wrong direction, even post some changes that we made recently at a federal level, for instance, the MME reduction or the morphine equivalent reduction. So understanding how these two parallel together in the one human experience is critical.
If I could, go ahead, John, if I could add to that, it strikes me that we're at a very risky time, and frankly, the numbers are showing it. The country is disrupted on the use of OxyContin and oxycodone. Health systems across the country are reacting in a shutdown mode and correcting things, including our organization. And I mean, that was one of the eye-opening things we found, is almost every health system across the country is facing this crisis by modifying their use of those prescriptions. The problem is this, that once you have addiction to it, it ain't going away because your prescription went away. What happens is you go to the street, because it's a crime to have addiction yet today, and people hide. Now, if you're addicted to OxyContin and your doctor starts shutting it off, you're going to the street, or you're going to find alternative sources. And that's where the risk comes in. For what it's worth, my son told me he was safe when he knew what he was getting through prescription meds. when that dried up and money dried up and you become dysfunctional, you go to the street and you're getting whatever's out there, and you can read in the newspapers all kinds of things about fentanyl and dose levels and everything else. And that's why the mortality rate has gone exponentially up in the last 2 years. And I think we're at a very serious point here to talk about how we're going to intervene, because if we push people to the curb, you're going to see the mortality rate go up like crazy. And yet, you know, our emergency rooms are front and center in this crisis. People who need meds are shopping for it, and if you're addicted, you're turning into using those meds to sell, to feed your own stuff, and it's a cycle downward. And I think we got to face that issue right now. There's no question we need to modify. We prescribe over 90-some% of the world's pain meds in this country. And we clearly went off tilt. But bringing it back needs to be very thoughtful.
Good point, Ed.
All right, very good. Jim, let's go with you on this one. As the title of our webinar asks, what is the CIO's role in battling this epidemic?
I think I talked a little bit about it earlier in my comments. The issue that I see is just the lack of continuity in the entire system. And when we're treating a patient, Ed alluded to this a bit as well, we've reduced our opioid prescriptions here. That's great, but we push them to the street. They end up somewhere else in the system. We've just tied together, as a part of our issue for addressing this, the largest homeless clinic in the city. We've just brought them onto our EPIC environment so that we're starting to connect with them. Once they hit the street, they often end up at that clinic. And we're trying to close the loop there, but we should be closing the loop with Intermountain. We should be closing the loop with all of the independent practitioners in the state. Somewhere over 85% actually report through our health information exchange, but the data is not getting back to the providers at the point of contact.
Yep.
When a patient comes in who already has an addiction, that the loop is not being closed, either here at our hospital with the information we have or in the community and in the state. It's such a local issue. And the CIOs, they can get together and start focusing on the data. How do we close the loop? Make sure we're intervening at appropriate stages, capturing the right data. And I don't see us really addressing the issue unless we know the addicted people as well as we possibly can, and that we're intervening appropriately. If we stand on the sidelines and don't pull the data together, I think we're missing a great opportunity. We're not just about technology, we're about patient care.
Yeah, and Jim, it sounds like what we're talking about is identifying the addiction and the person who's addicted, but not necessarily cutting them off with no resources for treatment, right? Because we said that's when they go to the street, and we don't want that. So it's got to be identification and then into some sort of treatment. Does that make sense?
Absolutely, and I think earlier the discussion around children who are born and almost immediately go through withdrawal. We have a service very clearly identified here. Who are the specialists in addressing that within the city? In Salt Lake City alone, the frightening statistic is that 1 in 8 babies are born with addiction and who immediately go into withdrawal. That's an area where we've closed the loop now, but there's so many other sort of similar situations where we don't have the entire healthcare community working together to make sure we've got the services for people who are addicted and intervening before they get to the street.
All right. If I could add, Jim, really great advice here. I think one of the things we found were some really advanced practices, but they're on a community level, so we got to share those. But one of the really cool things we heard from one of the volunteers here was basically in Healdsburg, California, they're working to identify frequent flyers, and basically they show up for shopping for meds, and instead of just giving them the med and sending them on their way or not, they're assigning them a caseworker to encourage them to get into treatment. I think that's very leading edge. The Geisinger did a webinar for us on their use of data within their, almost statewide accountable care organization. They're leading on practice. I'll just add two quick things that the task force has identified CIOs can do is, number one, learn about your statewide prescription drug monitoring program, PDMP, and how are you interfacing with it. What we found as a task force is there are almost no standards, and there is almost no sharing across state lines. And this is insane, that we are not monitoring controlled substances on a community or state level. That should be promoted, and in fact, about a month ago, California, out of the blue, mandated that as of October 1, all Schedule 2 through 5 meds prescribed must be checked at the state level PDMP before. Now, the problem with that is that sounds easy. The problem is that it's about 3 times the clinician workload, because that check and balance into the state PDMP is not automated or facilitated in our EMRs. And this is an area where CIOs and healthcare organizations need to step it up and say enough's enough, that we really do have a crisis on our hands, and it's time to get in the game here and really be thorough about checking and be thorough about who we're prescribing dangerous meds to.
Very good, very good. All right, I'm going to combine our next two questions together. Let's talk about other roles. So we're addressing the IT professionals, the CIOs in the hospitals. Who do they need to work with? And I want to combine the two questions. From an IT point of view, so the other IT roles, like the CMIO and the CNIO and the CTO, and also non-IT leaders, maybe the clinical leaders and other folks, CEO, COO in the health system. Jim, you want to start us off?
Sure. Probably the group that I work with most closely is actually under the president of our medical staff and the chief medical officer. They work very closely together. They've established a task force, and that's a group that I work with pretty closely. It's kind of a twofold approach. One is addressing many of the issues that we've already raised. How do you reduce the number of opioids that are prescribed? How do you get people into the right services? But the other side of it, as an academic medical center, that group also coordinates a lot of the research that we're doing around the opioid crisis. And it's a little bit unusual here in that they have a very large focus on marijuana as well. Although this state has not legalized marijuana yet, and unbelievably, they're actually talking about it now. So it's those are the key leadership people that we deal with. But outside of our own institution, of course, we're trying to work much closer with our local health information exchange, known as UHIN, and trying to coordinate with the leadership at organizations such as Intermountain Healthcare. So internally, of course, we've got our pharmacy folks involved, but I would say the big players are clearly the people at the top of the medical staff structure.
Ed, anything you want to add?
Well, I think that's part of this playbook that we're talking about and advice to CIOs and health systems, but I've been just struck profoundly with our just basic conversations here. I met one doctor who has, in our children's hospital, discovered a major link between wisdom teeth pulling and addiction. And it turns out that it's age correlated. Your first-time use presents you at a higher risk of addiction the earlier in age you are. And we found through our talking that dental offices are a major source of opiate prescriptions. And we need to check on that. And this is kind of, I bring that up because, as Jim mentioned, we're all acting independently, but we're not as a community. And we need to bring that together. I also found in our OB practice, we had been giving 30 OxyContin to every mother after birth. And I asked them why. And they said, well, we don't know. It was mainly for convenience. Okay? So every mother who has a baby has a bottle of 30 OxyContin sitting around. We've now reduced that to 5, and they're only 4-hour acting. They're not the 12-hour. But, I mean, every clinical discipline has got to do a look in the mirror on this right now. And I think by all these conversations and all the articles in the paper and all the headlines, we're finally acting. But again, I'll just caution us, be careful on the, one change doesn't make the system better. It's got to be coordinated and thought through.
It's unbelievable because you think about the fact that, to prescribe these things so loosely, and not only the addiction potential for the mother, but the potential of that sitting in the medicine cabinet and being grabbed by the child, right?
Yeah.
So, I mean, every single pill that's put out there, it better be for a good reason. And I think that's what you're saying. That's where we need to go.
Yeah. Yeah, we do. And our folks here are all over it. I just don't know if that's common throughout all healthcare organizations yet.
Right, right. All right, John, let's go with you on this one. Without naming names, how do you think, and you may not be able to answer this, but let's talk about vendors in general. You're a vendor. You're trying to attack this problem. Do you have any sense of how the overall community of healthcare IT vendors has responded to this? What are your thoughts there?
Yeah, I think my answer to this is actually conjoined with the previous question. So there's two parts to it. One, if you don't have an alignment between purpose, vision, mission, and values with who you're choosing to do business with and within your business, you're never going to have an alignment of an outcome. And in this case, I think the outcome we're trying to create is an end to the opiate crisis. So going back one step to the previous question, I would say Jim and Ed brought up some fantastic points about being cross-functional and leveling the playing field. Our team even reaches out to patients to get the patient experience to understand, what's happening from a legitimate pain prescription perspective, from behavior addiction. But the same parallel comes forward into the vendors. So if anyone that we align with at ProveIt, if we don't have a synergy around purpose, vision, mission, and values, we don't do business. I can give a couple examples of that. So part of our IT platform is around standardizing the education within the opioid space. So every year and multiple times a year, we always hear top policy officials come out and say the same 3 things that we need to do to end the opioid crisis. And one of those is well within our space. One's kind of out of it, more in a criminal justice realm. But the resonating thought is physicians need to spend more time with each patient. I would argue that we've defined the metric poorly. I don't know that the key metric is time, because we can measure time, and we can measure time on an output, and we haven't seen any difference in 20-plus years. But we can measure how we change the internalization of knowledge and behaviors, and we can also measure the change in addiction programs, right? And so if you're aligning to a vendor who offers that service whose vision, mission, purpose, and values are not aligned with yours and your organization to generate good care, that's going to resonate in the quality of the work product. That's going to resonate in the quality of the care. And ultimately what that means is we're okay with somebody dying as long as less people die just because I saved a buck or because I went with a preferred vendor. We're not okay saying that. I would make the argument that no one on this call is okay saying that. So to give a concrete example, ClearData is who we use for one of our IT infrastructures, and we're very, very closely aligned on vision, mission, and values and purpose. ClearData indicates that their strategies around sharing of ideas to change a healthcare practice, and one of our KPIs is mass customization to patient outcomes. So how can you use big data and IT infrastructure to enhance the patient outcome and make that predictable in big data science? But even our education module, so for one part of it is a video that combines what the 31 talking points along the 14 federal authoritative agencies say you need to know to take an opioid. Again, I'm a pain patient. Before ProveIt was started, I didn't know there was 31 talking points. I thought it was take as prescribed. That's a gap, right? And maybe there's 3 or 4 others, but I would make the argument that unless you've seen the program, that number may have been elusive to you. So one of our education vendors that we work through that makes this a whiteboard animation video to make it easy and simple to consume has a very similar purpose, vision, mission, and values as we do. And if you don't align strategically, you'll never align tactically.
Very good. Thank you. Jim, any thoughts on the vendor response?
Well, I think from the very beginning they've been actively involved with the task force itself, and what we're finding is the vendor community, they aren't sending somebody from their staff who just has time on their hands. They're sending their leadership, so they are very, very engaged. The one thing we're hoping to move towards is finding alerts that are fairly standardized in terms of doing the morphine equivalent daily dose calculations. A lot of our doctors practice in numerous facilities. They can be in one organization in the morning, they can be in another in the afternoon, they can be in their own office. So if we've got an alert that looks and feels and behaves the same way in all of our systems, I think 2 things happen. One, we've got better informed physicians, we've got better care for the patients, but we don't want to be competing on who has the best algorithm for doing the med calculation. So hopefully we can move to standardization across that, and we've had those conversations, and the conversations have been received very well.
Very good. All right, Ed, let's go with you on this. Talk about, and you did touch on this in the lack of integration. Talk about prescription drug monitoring programs. What's the CIO's role in administering or supporting them? And also an audience question, have you integrated PDMP into your EHR workflows? I think you touched on the difficulty of doing that, but if you want to address the issue.
Well, I think, as I said earlier, we're at a very early stage. The task force met with one of the primary PDMP vendors and got knowledge of their challenges in that. I think at a high level, PDMPs are outside the scope of the health system CIO. They're usually organized under the State Department of Health. Alternatively, then, like in California, they reside under the Department of Justice. And so we really need to take a national look at what are our standards for PDMP deployment. Are there going to be standard data sets so that health systems and vendors can better interface with them and utilize them in their workflow? Today, they're outside of that clinical workflow and are additive, which is a serious problem. In the states that have mandated PDMP check on prescription, there's very low compliance because it's just not feasible. So CIOs, we got to work better on this and push for both changes in regulation and requirements, but also standards on interfacing and data. One of the big things that is a barrier is our privacy laws. And for example, the patient must consent to their data being shared, and I know there's some new legislation going on recently at the federal level about kind of breaking that down for the benefit of the patient. If they have the disease and they're out shopping for meds, my God, let's identify them. But we're not near there yet. And the other thing I think CIOs can do beyond PDMPs is promote electronic prescribing of controlled substances. I don't know the statistic on that, but we're ramping that up. But that's another way to get at electronic data that's identifiable and shareable if we're on electronic prescribing of controlled substances.
Very good. Jim, audience question I want to get to. Tell us, and I think you touched on the community issue, tell us what any CIO can do to support and advance substance abuse initiatives in her own community. Tell us more about the resources available for the CIO's education.
You know, that's an interesting question, and it's one that, you know, personally, it's been almost an individual search getting in touch with the right people in our state. Part of the, I mentioned earlier, the playbook, and we hope within the playbook that we'll have sort of a list of who are the resources you need to reach out to, or what are the functions you need to reach out to within your own state. And as I've worked through this, that's the playbook is something I wish I had in my hand 6 months ago, because it's different in every state. I mean, there's no doubt in my mind that this is a very local issue. So I can't tell somebody, okay, in Montana, here's the people you should touch base with, but it's the role that we need to touch base with. And I think our role as CIOs is to collaborate, see if we can get people working together and tighten up the loop so that everybody has access to the same information, and we know how to intervene and who to intervene with. So I can't give a specific answer state by state, but part of the playbook issue that will be coming out later is who are the right roles that we need to connect with.
Mm-hmm.
Very good. All right, let's get to our Ask a Co-Panelist feature. John, I'd like to give you an opportunity to ask one or both of your co-panelists a question.
Absolutely. I think I'd like to ask the first one over to Ed. You were describing kind of a threefold path and the need for policy change and how that plays into the clinical role and the role specifically within hospitals. What are some of the largest challenges that you foresee in both at supporting clinicians in a cross-functional space, but more specifically as a CEO, as they adopt to the new norm and lower prescribing rates of Class 2 meds?
John, I guess I missed your question. Can you just restate it?
Yeah. What do you foresee as the biggest challenge?
Roadblock.
Roadblock as CIOs within large hospital systems adapt to returning to a new normal with reduction in Class 2 and opioid medications. Do you foresee any challenges that would impact your architecture and your systems and your space as we try and resolve the opioid crisis?
No, I don't see that as the problem. We clearly have we have automated EHRs, 97% of hospitals. I think that what I'm concerned about is the unintended consequences piece, that, we can shut down opiates at the hospital level, but that doesn't mean people aren't still addicted. I think the biggest challenge is privacy, that I struggled with this as a parent and a family, and we didn't make any headway until our son and us insisted on open transparency with the clinicians, with people in treatment. And so that's a big barrier yet, and we need to think about that. Are we really, if really the intent is do no harm, is that really being upheld by keeping data confidential that this person has addiction and they just shopped at the ER across town? Okay? That's a big deal. The other thing And I'll just say where we're limited, in my opinion, is addiction management is not done in hospitals. It's done in community health centers and private organizations that,
God bless you,
until healthcare reform, weren't even reimbursed. So, I mean, we have a long way to go to understanding that a 7-day detox program is not treating addiction. It is doing almost nothing. And that this is a long-term care issue, that care involves every element of healthcare in the community, not just siloed entities. And this is not an acute illness. This is a chronic illness. And that's where hospitals really need to take a longer look at this thing and basically bond together at a community level to solve it. And I think the Geisinger example I pointed out is a great example of that.
Very good. Jim, I wonder if you had a question for John that he might be able to offer some insight.
You know, John, I guess the thing I'm concerned about is, as much with the vendors as with the hospitals and the communities, is people functioning independently. And how do you see the vendor community bonding together in a tighter way, and getting them to agree on some common approaches?
I think there's two answers I'd like to, two parts to an answer I'd like to propose to that. One, sort of internal and albeit micro compared to y'all two and those on the phone on how we handle it, and then one kind of macro that scales, in my opinion, fairly well. It kind of resonates with the alignment towards purpose, vision, mission, and values. So if we have the same agreement and consensus on that, then it's a pretty easy step to approach, which gets us to solving the end goal. And then from there, we just have what are the inputs to getting to the end goal, so open communication, transparency, and whatever legal or compliance documents are needed to get in order to do that in a secure environment and one that's free of litigation. But I think the big rock that we got to make sure that we go into is establishing that foundation of open sharing, similar to what Ed was saying under the do no harm. And if you have someone that's an addict at the micro level, at the patient level, at the individual sample size level, we can replicate that at a larger level. And to the smaller answer and how we've done it at ProveIt, we've created a couple forums. One where we're sharing some of these best practices and big data and infrastructure components that discuss this. One goes right in line with a resonating point both you and Ed have brought up, which is around the counterintroductory point of reduction in MME to the death count. So not looking just at addiction, but the mortality rate. The MME rate has reduced since 2010, but the death count has gone up. And if you look at it statistically, we did the data on this and published it about a month ago. We didn't do a causal analysis, it's correlational, but it's something to the effect of, and I don't have it right off the top of my hand, so give me plus or minus 1%. I think it was like 98.27% correlated to a death count. So the further we reduce the MME without having the right infrastructure, practice, and behaviors in place, probably about a 98.2% chance that you're going to have another opioid-related statistic on your hands. So how do we share that data? How do we integrate it? But we also have systematic and automated alarms and communication methods within our platform that we allow us to share within our physician providers and within our network, our community of practice. So as we're seeing something that comes through that's not aligned to that desired outcome, ending the opioid crisis, we can bring it up to the front, rest on that one laurel that we all have, rest on that one rock that we all have the same end goal in mind, and then accomplish it through data.
Yep. Okay, thanks, John. Appreciate it.
All right, we got to wrap very soon, but I want to give Ed and Jim one final opportunity, and I think we have this question at the end of all of our webinars. I don't think it's ever been more appropriate. Ed, do you have a key request or challenge that you want to give to those that you're going to reach in this webinar, something you want them to go back and do specifically?
Well, I think that to help out, you should find out what your organization is doing and also how you are interplaying in the community. I just want to highlight 2 examples. When I went to our emergency department, the children's only part 3 years ago, before I went to Washington to testify on this, 70% of the patients were behavioral, and we are a surgical hospital. We had nowhere for them to go. And I gotta believe that's happening in every emergency department across the country. Stanford in Palo Alto is not unique. And so understand the problem and understand how you can better play with your organization in the community to help this problem. That would be my ask.
Excellent. Jim? Oh, I'm sorry, Ed, were you finished?
Well, I think one of the great things, and I meant to mention it, but in our organization, we have a teen van. It's a mobile clinic that treats homeless children under the age of 17. And a significant population they're dealing with is substance use disorder. And one of the, as Jim mentioned, we put that teen van on our EMR, and because of that, they can see data across the entire Bay Area through our sharing of data that goes on. So there are initiatives out there. They're making headway. I'm a fundraiser, actually, for the teen van and a personal sponsor, and I've gone out on it to see it in reality. I would encourage CIOs to see the problem differently.
Jim?
Yeah, I would go back to a conversation I've often had with Ed, and that Ed has emphasized and has hit home with me many times, and that's to make sure that we recognize that addiction is a disease and to destigmatize it. And we have got to move in that direction, and as CIOs and as humans, that is something that I think is really critical, that we make sure we get that into the conversation and just hammer on that theme consistently, that we need to treat this as a disease and not stigmatize the people who have an addiction.
Very good. Well, that's about all we had time for today. We've gone usual than our longer event, but I think it was appropriate and worthwhile, and I couldn't have asked for a better panel to comment on this issue. When you close out of your WebEx window, you're going to be taken to a post-event survey. If you could take a moment and answer that, we'd appreciate it. Regarding continuing education, those of you who hold the Chime CHCIO certification get 1 credit for attending our events. Let Chime know you were here, and if you've asked us to do so, we will. You'll receive an email when our archive recording of this event has been posted to our YouTube channel, and if you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox on our team. You can also view our website to see our upcoming schedule. So with that, I want to thank our panel very much, Ed Kopetsky, Jim Turnbull, and John Cruz, and I want to thank ClearData for sponsoring this event. I want to thank you for attending. Everybody have a wonderful day. Thank you.
Thanks, Anthony.